What I was gonna have is an alien escaping a chest of a. Anyway, it'll be for my favorite cohort. We'll do it on the next one. All right. As per usual, I want to bring up some anatomy, but largely just kind of blaze by it because there's not a whole lot to do with anatomy that isn't essentially just pointing it out and having you kind of flashcard it to death. Now, the thoracic cavity, the reason why I put that there and the reason why I kind of highlight this is that oftentimes people just associate chest with thoracic cavity because we have an abdominal cavity, and I think that's fine because that's technically what it is, but it's rare that you have it in isolation. In fact, I think even the book, it says if a person is laid on the ground, during exhalation, the diaphragm sometimes relaxes all the way up to nipple line, which I think is interesting. What I guess I mean to say is that yes, the thoracic cavity is neck to diaphragm, but just make sure you know that that diaphragm can go up very high and can go very low, in the sense that if we suspect chest trauma, we should suspect the possibility of abdominal trauma as well, put pretty simply. Now the mediastinum is referenced. I threw my entire presentation into ChatGPT as a text, and it was like, wow, you talk a lot about mediastinum. You should consider not doing that. Shut up, stupid robot. I disagree completely. I think that the mediastinum is worth talking about and referencing and making sure that you understand what I'm talking about when I say it, because it's often just kind of confused as the thoracic cavity. So we have the mediastinum, which largely encompasses the heart and then the associated great vessels there, like vena cava and the aorta. And on either side of my mediastinum is my lungs and the pleural cavities, not the mediastinum. Yeah.
I know that both lungs are not symmetrically shaped as shown here.
Mm-hmm.
Do they both have equal volume, though?
I don't know. I would assume so. They have, part of the reason they're not equal shaped is because they have a differing lobes. Mm-hmm. I always think it's cool because, like, if you're trying to remember the leaflets of the valves, essentially there are 3 on the side here because there are 3 lobes, so you can just kind of associate that. I don't know. I would assume so, because we just, I think, offhandedly say, oh, if you have lung collapse, you've now lost 50% of your tidal volume or whatever, but I don't know. I just assume that. It's important to remember the contents of the mediastinum. I don't remember if it was this year or last year, but it's just a very simple question that says, which of the following select all that apply are in your mediastinum, right? Now, I'll always forget the esophagus because I don't super care, but it's technically going right through there as well. And so this red area largely represents that, unless you count the esophagus trailed behind it. Part of the reason I bring this up is because it's not just mediastinum equals heart and pericardium. It also has, like I said, the aorta and the ventricles. It also has the trachea and even the bronchi, both left and then the right main stem. All of these things are in that little space called the mediastinum. What is also flowing through there is our phrenic and vagus nerves, which are 2 things that we're going to talk about. Now, there are, how many cranial nerves? 12? Is that right? Something like that. I don't care that you know basically any of them. We aren't going to talk about them. The book even goes into some depth on what's called dermatomes, which is different than the nerve stuff. Dermatomes are like me saying, oh, do you have sensation here? Because that's this part of the spine. I don't think it's valuable to you. I think it's super misleading because it makes you think that it's the same as spinal issues, and it's not. So I don't have anything on dermatomes. You can ignore that part in the book. But what I do care about is you understand phrenic nerve, first of all. Hopefully this is review. C3 through C5 keeps the phrenic nerve and diaphragm alive, right? Very good. Thoracic nerves essentially are intercostals. The reason I bring that up is because I've seen questions where your guy suffers traumatic spinal damage at this location. What's his breathing like, right? Now, here are some of your cervical spinal processes, these pins coming off the back there. I want to give reference. The amount of times in my career I've seen somebody with an injury like way down here and people are like, oh man, that's like a C2 or whatever. I'm like, no, nope. The cervical spines are way higher. Now, the real landmark here is, of course, the one that you can touch. If you touch 7. Yeah, and you push hard enough, you can touch them all except for 1, because number 1, the atlas essentially is way up there. But if you put your hand on the back of your head and then slide it down, that big step off you hit 99 out of 100 times is going to be the C7. Now, I don't care that you know that. I don't have a test question that asks you that. That's mostly just to save you in a radio report and an embarrassment in a trauma room where a doctor is like, C2 really guy, it's in the middle of his back, right? So C7 is right there, which means our diaphragm is being innervated up here, which means essentially that if I have a person with trauma, I'm looking way up here, way above C7. So the reason I'm saying all of this and I'm concerned about all of this is that if you have spinal trauma in this area and your patient is apneic, that is an easy mystery to solve, right? We have spinal disruption and apnea. If you have spinal trauma and it's below that and your patient is apneic, that is not an easy mystery to solve. It's not his spine that caused the apnea. Are you with me? Okay. What might have happened if I get a guy gets flung out of, Sam, if I get a guy that's flung out of a car and I say that he's got thoracic spinal damage and is now apneic, what would you suspect the cause might be? Maybe. Well, maybe, depending on where it's at, right? I wonder if I'm asking it too vague. Is anybody following me?
Yeah, like anything else.
Anything else is my point.
It's not intervention.
If I take scissors and I say, well, let's play like this. Okay, Sam, I take scissors and I cut you at C1. What's your breathing like? Spontaneous. Opposite that. No. None. I cut you at C3. Right? Oh, I guess I'm saying, yeah, I see how that's misleading. I guess. I mean, this is where it's innervated, which means if you have trouble, you no longer have these things. In short, I guess, if I snip the wire at C1, I have apnea. C2, apnea. C3, apnea. C4, I'm starting to not be apneic, but my intercostals are no longer working because they're
Then what do you mean by spontaneous respirations for C3 or if it's just apnea?
That's where your spontaneous respirations come from. They're innervated. Your spontaneous respirations are occurring because of C3 innervation.
So you're not saying that if you have an injury at C3 or
No, but I'm seeing a room full of faces that largely agree with you, so I can see how perhaps that needs to alter in some way. I'm like, kind of, unless I back it up, because I said to Sam, I say, hey, if I cut your spine at C1, and he was like, oh, I have spontaneous respirations. So I'm like, okay, obviously not that, but I can appreciate how it's misleading wording. What I'm trying to get across here is be careful in this area. I'll say that your patient has been, received spinal fracture at C5. What should you suspect his respirations are like? And apnea will not be the answer, because the diaphragm is largely innervated above that, right? Yes, C3 through C5, phrenic nerve and stuff, but it's going to have its most dramatic effects the higher up it goes around C3 or so. What I'm saying here, I guess, is that if I get a C6 fracture, for example, my diaphragm might be working, but my intercostals are not. In a certain sense, it's kind of like the atria. Can you live if your atria are not overfilling the ventricles, but merely filling the ventricles? You can live, right? But it's not great. It's far less effective. Can you live with only isolated diaphragmatic innervation? Sure. But those intercostals do a lot of work to pull the chest cavity out and increase the negative pressure, which is important not just for air, but what? Carbon dioxide, gas exchange, perfusion. It's also very important. That negative space that's occurring in your chest is causing, in large part, blood to rush into your right ventricle. Which means if I push I think before you came in here, you knew that if I put my hand against your chest for long enough, that would make it difficult to breathe. What I hope you know in AEMT class is that you know that it will also make it difficult to perfuse, because not allowing chest expansion is going to minimize the amount of blood return. Super nice. Yeah, that was fun for me too. Okay, so that was phrenic nerve. Phrenic nerve is largely innervating your diaphragmatic spine. And now we're going to, diaphragm. Now we're going to talk about vagus nerve. Now, what is, if I were to say, one of the primary sympathetic nervous system organs, you would say? Adrenal glands, right? That's where epi is getting made, which means that if I could reach inside and grab your adrenal glands and squeeze it, what would probably come flying out? Epi, norepi, cortisol, right? Yeah, absolutely. Now, The vagus nerve is like the adrenal glands of the parasympathetic nervous system.
The nerve is?
The nerve is. It's not like some organ sitting like a little kidney hat somewhere. It's a wire. This nerve is the equivalent of the adrenal glands for the sympathetic nervous system, which means if I squeeze an adrenal gland and epi comes out, what happens to your heart rate? It goes up. If I reach in and I squeeze your vagus nerve, what happens to your heart rate? It goes down. So this, I guess, metaphor here, this image, is to say that this vagus nerve is like the chain holding back the dog that is your sympathetic nervous system. Which means that essentially, if I reached in and snipped your vagus nerve, I'd be snipping the chain, and now the only thing that would be affecting your heart and body would be the sympathetic, and your heart rate would go up. Yeah.
Anatomically speaking, is it just up here? Does it go follow along down the spine as well?
I'm glad you asked. The reason why this picture is super important to me, not only did it look awesome, but is to point out, because I want to really nail home this concept of neurogenic shock. Do you see how coming out of her cranium are these two yellow nerves that go down alongside the spine? They affect the lungs, they affect the heart, they affect the gastric system. Do you see these? Okay? That's why we call them cranial nerves. They're not in the spinal cord, and they're leaving the cranium and going and innervating things. This yellow representation is your vagus nerves. If I hit you with a baseball bat and I snip your C7, it's going to interrupt the neurological pathway trying to travel down your spinal column. But the vagus nerve, the parasympathetic adrenal gland equivalent, aren't in the spinal column, which is why you get bradycardia with neurogenic shock, because you're not disrupting the vagus nerves. Yeah. Or at least,
What is the difference between brain and the spinal?
yeah.
You said that the nerve itself is kind of like the adrenal gland. Does the nerve contain the hormones? Is that where they're released?
Creates, yeah, and released. But even in the sympathetic nervous system, we also, like norepi comes primarily from nerves that are similar to this, not the adrenal glands. The nerves themselves will emit the neurotransmitters.
And those aren't like vessels, that's just like a straight, that's a large nerve.
Yeah, dude, yeah. It is. But if you can hear that sound, that light buzz, that is the end of my knowledge. That was my tape deck returning. That's as far as I can go down that path. Now, you can stimulate this by firstly bearing down, and in fact, the paramedics will teach you that in paramedicine. If somebody has a high heart rate, one of the first steps is to get them to bear down, and what they're doing is putting pressure on the vagus nerve. The pressure of that vagus nerve is releasing the parasympathetic version of epi, called acetylcholine, and that is causing their heart rate to go down.
People faint.
Yeah. Mm-hmm. Interestingly enough, this vasovagal syncope rather, you experience these mostly when like you're sitting on the toilet, geriatric person that doesn't get good blood return, they squeeze down to give them a daily constitution. They vagal themselves out, right? This is not the same thing as people standing at a wedding and passing out. That's more just like venous pooling, and so you're not getting enough blood return because your knees are locked up. But what's very interesting about this as well is that in our arteries, right? And so let's picture a heart down here below the aortic arch. This comes up like this, and then it goes off to our various parts in our body, these arteries. In our carotid arteries, we have baroreceptors, both in the arch and the carotid bodies. They are literally determining the pressure that is happening right there. We used to teach, please listen when I tell you, we used to teach paramedics to do carotid massages to lower people's blood pressure. All it was is I would be like, whoa, you're hypertensive. I'm gonna find your carotid artery. How do I know it's this carotid artery, not his jugular vein? Good job, you're such an embarrassing moment for me in my life. I asked a nurse who was doing arterial blood gas draw. She was like, whoosh, way in there. And I was like, dang, like how do you, if you're that deep in, like how do you know where the artery is? And she was like, it has a pulse. I was like, So all we would do is be like, hey, your blood pressure is really high. And we would massage the carotid artery. it would compress the carotid artery, it would trick the baroreceptors into saying, oh, the blood pressure is really high, I should emit hormones to lower it. Does anybody know why we stopped teaching that? Stimulation of the vagus nerve can lower your heart rate, and when your heart rate is too high, that's great. But when it isn't, it can lead to things like syncope because your brain isn't getting enough perfusion. But it can also innervate laryngospasm. Does anybody remember us talking about why we're very careful about suctioning the neonates? Because you can trigger a vasovagal response and it can cause laryngospasm. We also learned that massaging the massage effects of the vagus nerve, yes, it did all that stuff, but it also released clots that were in the carotid artery. If you're just rubbing an atheroscleroserized artery, you're going to potentially dislodge clots. And so we're like, okay, there's minimal benefit to a carotid massage. There is a very serious danger here if we dislodge a clot and turn their high blood pressure issue into a STEMI, or a stroke for that matter. So we don't do that anymore. But it's important that you know what the phrenic nerve does and what the vagus nerve does and how it affects things. I think we kind of hit this point already. Essentially, this is just saying, I look at something like this and I think, oh, that almost looks like a dermatome, but this is innervation of the musculature largely, not the sensation. It's a different concept. We're going to talk a little bit, do some review on the mechanics of both ventilation and respiration. Which one of these two things is explicitly external respiration? Oh, it says it in the name. Never mind. Just kidding. What you need to know about inhalation is not just that that's when the air goes in. You also have to know the terminology, essentially being able to differentiate that we have expansion of the chest, that it's an active process. What do I mean when I say active process? It's using energy, which means if you ain't got none, you can't do that. Turns out if you're dying, sometimes you die from it. That's a summary. The muscles contract. Which muscles contract? Diaphragm and intercostals. Are intercostals considered accessory muscles?
Yes.
I don't think so.
Is that like the arms? Is that when we're talking about like
Shoulders, SCM stuff. The idea is this: it is normal for your intercostals to work while you're breathing. It is a primary breathing muscle. Retractions are happening when there is unnecessary involvement, not unnecessary, it's necessary to live, but when there is excessive involvement of the intercostals. It creates negative pressure. Can somebody explain that like I'm 5? What do I mean when I say negative pressure?
Holding a vacuum.
Creating a vacuum, right? Absolutely. John, what's the Herring-Brewer reflex?
I don't remember.
Okay. Jack?
Your lungs stop feeling automatically.
Yeah. Does anybody remember why we get the urge to pee? Stretch receptors, right? The bladder fills. What else could instigate the response to pee that isn't the bladder filling up with pressure, a baby, right? It's literally responding to the pressure. And the Herring-Brewer reflex is a stretch receptor essentially saying, hey, once I get to this point, I'm going to cease function so that way I don't what? Explode, yeah. So I don't explode. That is correct. Expiration, which I hate saying because it makes me think just like somebody's death, expiration. Exhalation, it's a passive process, right? It doesn't require energy to just return my chest cavity to its regular state. The muscles relax. And so therefore the only positive pressure I'm getting is with BVM and CPAP, right? Because otherwise breathing is a negative pressure. Do you remember from an earlier conversation today why I think that it's important? Now we laid this groundwork in EMT, positive, negative, but what did I say today in regards to why a vacuum in your chest is very important?
Is it blood return to the heart?
Blood return. Blood return. Movement is super important. People that can't move their legs have a hard time perfusing well because the literal contraction, that's why they sometimes will say like, hey, every hour or whatever the timer is, like get up and walk around a little bit. The literal contraction of your muscles, some of the biggest ones in your body and your thighs, is helping create that flow of blood. It's super important. I think they go on to even show like an echo or something, which is kind of cool too. How it moves through. Please close. Please next slide. Here we go. Ooh, let's get rid of that. Who knows what? Doobie doobie doo. There we go. Oh boy. What's funny is I'm trying desperately to get this to return to a normal state, and I don't even care about this slide. There we go. So we talked a little bit about ventilation. We talked about respiration primarily in our airway and respiratory chapters. But of course, you know, ventilation is important for the expansion, return, and exchange of gas so that respiration can occur. But respiration is occurring directly here at the pulmonary vasculature and the alveoli. Now we know cardiac output is heart rate times stroke volume, right? Essentially that's what's happening in a single minute. And if you tip the scales on either side, too much, too little of either one of them, it can be a problem. Could a heart rate that is too fast lead to poor cardiac output?
Less overfilling of the ventricle.
Less overfilling, less filling in general, right? If I don't give it enough time to fill and overfill, then that's going to be an issue. And so our ability to pump is affected by a lot of things, but this is just one of many triangles we've kind of talked about, right? Having a good enough pump, having a good enough amount of volume, having a good enough amount of pipes or vasculature. Now to talk a little bit, this is really just my way of saying, hey, I want aortic stenosis to stick in your mind. Okay, that's the real hook here, aortic stenosis. Stenosis essentially means to harden. And so if your aortic valve is stenosed, it's hardened and it's no longer opening as well as it should, which means where is blood going after it passes through your aortic valve? Yeah, right? The entire body, yeah. And so essentially, if your last door out of your heart is stenosed, what's that going to do to your afterload?
Increase it.
Increase it because it's pushing against this it's like putting your thumb over a garden hose. Yes, that is going to increase the pressure, but that's because the pressure had to escape, essentially. Now, aortic stenosis is not great. That's one of the #1 causes of this pathological afterload. What do you suppose happens to your heart if it has to push against a higher pressure constantly?
Tires out.
It will get tired, but to survive, it must get stronger.
The walls will thicken.
The walls will thicken, and we call that hypertrophy. Hypertrophy. Have you ever heard out in clinicals or whatever the case, left ventricular hypertrophy, LVH? It'll be all you talk about when you get to medic, probably. The idea is this: if I want my biceps to get bigger, and I don't because they're probably at max capacity, but if I want them to get bigger, I would want to put higher and higher resistance against them. That's how my biceps would get bigger. And the same thing will happen for your heart if it has to pump against higher pressures. Like in the case of systemic hypertension, if you said, hey, why is high blood pressure even a problem? I'd say, well, because your vasculature is like balloons all throughout your body. It's wrapped inside and around many of your organs. If your blood pressure is too high, then your balloons, your vasculature is expanding too much, and that can lead to all kinds of problems. But it's not just the systemic, it's also the pulmonary. If you have pulmonary hypertension, then the other part of your heart will suffer and potentially die. They call that cor pulmonale. I think it's probably Latin, maybe Greek or whatnot. But it's like lung heart or something, pulmonary heart, right? When you have right-sided heart failure, that's called cor pulmonale. So pathological afterload, to kind of walk it down, if you have to press against a higher pressure, whether it's because you have high blood pressure, you have a stenosed aorta, you're going to increase your myocardial oxygen demand. What's a non-fancy way of saying that?
Your heart demands
Heart
more
needs
blood.
oxygen.
Heart needs more blood, heart needs more oxygen. That's right. Now, because you're pushing less and less, or sorry, going to have to push harder and harder against it, we're causing a backflow issue in some ways, right? If my heart requires more oxygen and I can't get it through on the other side, my stroke volume is going to go down. If my stroke volume goes down, essentially, that's all going to lead towards left ventricular hypertrophy, right? A muscle that is growing too big beyond its case. It's very different than if you said, well, I run for an hour every day. Is my heart getting bigger? I'd say yes, probably. And you'd say, is that hypertrophy? I'm like, no, hypertrophy is pathology. If your heart is beating all day long against a systemic problem, that is not creating a healthy heart, right? That can lead to heart failure, that can lead to ischemia, that can lead to infarct, that can lead to death. Now, one of the things we also have to consider as we talk about a lot of these topics we're somewhat familiar with is not just that a hole in your lungs is bad, which, spoiler, it super is, but it's also leading to the change in pH. Why could chest trauma lead? Can somebody give me an example? This trauma happened, now I have respiratory acidosis.
CO2 escaping, so no, the other way.
The other way.
Oxygen escaping, so you become acidic because of CO2.
No, you're not wrong. I just want to know what might cause that. Sebastian.
Like a pulmonary contusion that affects
Lovely.
the
That'll do.
alveoli.
Yeah, so if pulmonary contusion is like a bruising lung. If your lung is bruised, a portion of that isn't working as well as it should. If a portion of that isn't working as well as it should, then it's not exchanging gas as well as it should. And if it's not exchanging gas as well as it should, we're starting to have a lack of oxygenation and a retention of carbon dioxide. So all I mean to say is like, look, we left EMT school and I was like, hey, turns out if your lung is damaged, that's a problem. And you're like, got it, boss. I'm like, cool. Now you have to know why it hurts your blood too. You're like, but you said lungs. And I'm like, I know. But as you're not getting rid of the CO2, it's increasing the creation of carbonic acid. The increase in carbonic acid is shifting your pH. The shift in pH is doing what to your hemoglobin and the oxygen binding? Having major issues, right? Do you remember what you were going to say, Sam? Do you have an example of it? You're like, hell no. That was what Sebastian said. You know, the point is this. What I'm really trying to get at is that, I should probably back up. Get ignored for 40 seconds, is hypoventilation. Any chest trauma causing hypoventilation is going to lead to respiratory acidosis. So, yep, pulmonary contusion can lead to poor gas exchange. What other traumatic chest condition can lead to hypoventilation? Your chest is hurt. What kind of chest hurt is making you not breathe well? Penetrating trauma, yeah, but it would have to be a little bit more specific, but yes. What do you say, Lauren? Okay. COPD isn't going to be trauma.
You got neck penetration.
Tension pneumo, right? Just like Henry said, yeah, penetration, yes, but if it clips the lung or disrupts
Blood goes in.
hemo, sure. Or like an ARDS, maybe. Now, we have all kinds of different chest injuries, blunt and penetrating, and they all can come with similar issues, right? In fact, in many cases, it's difficult to differentiate them. Fractured ribs we'll talk about, fractured sternum, bruising and tearing of the lungs, pulmonary contusion, you already said that, boy must read the book. Bruising heart, it's like my first course or whatever, I was like, I never even heard of a pulmonary contusion or a coronary contusion. I mean, I guess it makes sense, but like, who cares or whatever? And then they all come back from the test and they're like, it was all over the place. It wasn't always the right answer, but it was just, so I had to look into it. Of course, I'm like, how am I supposed to know this? It's just all over the book. Oh, okay, got it. But in short, like, we're somewhat used to bruises because some of us have experienced it on the regular. But if you get a bruised heart and a bruised lung, those are highly specific organs. And if that area is taking on fluid or damage, it's going to be less effective. And you don't want a less effective lung or heart. And so it's a much worse issue. Then we'll talk also a little bit about aortic rupture and what that might cause. We've talked in the past a bit about dissection and the like. we'll get into it here. One of the things is I don't mean to say that a guy is like, oh man, I fell and now my chest hurts, and you're like, boom, putting AED pads on him. But it is interesting to me, skull trauma and chest trauma are two of the only instances where I'm getting an AED ready or perhaps on beforehand, right? Like somebody's like, oh, well, this guy shot himself in the head and he's unresponsive, but his heart's ticking along fine. Why are you putting him on the AED? I'm like, because his brain is injured. The next thing I can think of is going to be his heart, you know? So I don't mean all blunt and penetrating, but it's not crazy to consider it, that's for sure. If a guy got shot in the chest, I don't think it's too short of a line to draw to say, hey, this might result in a coronary issue or cardiac issue. I wanted to just list a couple of different things to make sure we could cover some terminology here. Obviously, one of the dead giveaways for a chest injury is going to be pain or dyspnea, because if it's not the lungs, it's the heart, and if it's not the heart, it's the probably, right? Yes, we want to look for DCAP BTLS. Listen to me when I tell you, be very careful going into your practical and just doing your physical assessment like this, like, hey, any DCAP BTLS of his head? And they're going to be like, they're probably going to say no, but if you don't check everything, you might just get a no and be like, well, I said head. And I'm like, yeah, but you just did this, and that looked dumb. You're dumb. You know, be very careful. We won't have a live actor, which means you should be exposing and palpating and all this stuff, right? You don't want to go and lose a bunch of points for arbitrarily being like, and his chest, DCAP BTLS? Be like, okay, well, be careful, because there are some injuries that don't fit in that. You don't cover everything. Like, can anybody think of something that would be wrong with the chest that isn't DCAP BTLS?
Unequal.
Puncture, unequal chest rise and fall. If you just say any DCAP BTLS and the guy's got a flail chest, because that's what we picked for the practical, that's going to be trouble.
Paper bag syndrome.
Yeah, paper bag. What is crepitus?
Sensation. That
Crunching when you're
the bone.
like popping or cracking through the bone, or like air.
For a lot of my career, would describe subcutaneous emphysema as crepitus. I don't think that that's technically true. Subcutaneous emphysema? I don't know. I do not believe you. But what I'm sure of is that it talks about the broken bone ends rubbing. Now, personally, they feel the same to me. So, I don't think that it's crazy to make the association. I just want to make sure that I'm pretty sure that the literal definition is the bone ends thing, that subcutaneous emphysema is a little bit different. But physically and anecdotally, they felt the same to me. Hemoptysis. I say hemoptysis, you say? Right? But if you've got flung out of a car, we're less inclined to think that, right? Why would a guy that get flung out of the car have hemoptysis but not have a fever?
Trauma.
Yes. What? Thank you. Lungs are bleeding. Say it again. Huh?
I would say sometimes you get cough, blood, it doesn't mean that
You can. I just watched Eddie Hall, Strongest Man in the World or whatever. He lifted, and it just blood just comes out of his mouth. Yeah, man. It's just the amount of strain and pressure causing this shift. Amazing.
You had to be hypnotized.
Yeah, I saw that. That's where I got the thing. I saw that too. He just pictured his kids. Circulatory collapse, for sure. If I've got a guy with a penetrating trauma to the chest, he develops into a tension pneumo, and then I have widespread issues, right? Pulsus paradoxus. What's that? Drop in BP when? Yeah, on inhalation. Now, this falls into a category of often confused things in EMS. Pulsus paradoxus, the signs and symptoms of a dissected aorta, and something called pulsus alternans. You don't need to know that necessarily. All I mean to say is that I've seen pulsus paradoxus pop up wrongfully in many ways. What this means essentially is when you inhale, what does your chest wall do? It expands. What's happening to the pressure inside? It's increasing, but it's negative.
Yeah.
Right?
Yeah.
Yeah.
Pushing it down.
So what happens essentially is you inhale. It is actually normal to have a blood pressure shift on inhalation. but not essentially to the tune of 10 or more. You ever check a blood pressure twice in a row and get very different numbers? It's possible some of that changing number was contributed by the fact that you caught them on an inhalation on one and an exhalation on the other. There's a normal shift there because pressure's changing. But when it gets extreme, that's an issue. As the pressure increases, left ventricular filling decreases.
What do you call it extreme? Like super far away?
Greater than 10.
Okay.
Now, I would hope that you would kind of get to the conclusion of cardiac tamponade through a different pathway, that through other signs and symptoms like JVD and the like, you would start to think tamponade. But pulsus paradoxus can help you if that is the key that gives the whole thing away. Take a quick break. That.
I have a question
So,
about like C-spine considerations in scenarios.
C-spine consideration in scenarios. Yep.
Sometimes I feel like I'm in a scenario and it's like, you know, you get to consider C-spine step or whatever, and you're like, and I'm like, okay, I'm gonna do manual
Yeah,
C-spine
absolutely.
stabilization.
Almost never wrong.
Right. I do, you know, physical assessment.
Yep.
Check out the neck. Nothing noted.
You're like, cool.
Yeah. Well, at what point would you say like this is not warranted for someone who's like unresponsive and it's trauma?
Okay. You are not wrong to be confused, and part of your confusion is being experienced because we are kind of in flux, where we're all pretty sure that the registry is still following adamant C-spine precaution issues, and we're also all pretty sure that the field is barely starting to do that, and thank God, essentially. But if we go to the answer to your questions of when, oh dear, you want to see your schedule lined up? Mr. Fearon's brain. This isn't what I wanted. Is NSAID criteria
Okay.
one of your intervention cards? So, put pretty simply, if the question is, when do I give aspirin? I'd say, well, what's the indication, right? If you say, when do I apply my full immobilization? I'd say, well, what are the indications? And the indications are a significant trauma mechanism, which is vague intentionally, and then neurological deficit like paresthesia or weakness. Then if they have an altered mental status or level of consciousness, if there's any chance there's intoxication or distracting injuries like a broke thumb, broke arm, lots of blood, anything to make them think my chief complaint isn't my spine. Or simply pain or tenderness, meaning like pinpoint, right? So if you're in a scenario and you say, well, they qualify for one or more of these things, I want to do a full backboard, you would be in the right. The clinician that's running your scenario probably wouldn't be doing that in the field, but we're not convinced the test won't make you.
People think it's so bad when you did RSP. You told me no full immobilization.
I was wrong.
That's a full immobilization.
Well, believe it or not, sometimes I don't know what I'm talking about.
We literally have the same card the same. We don't full immobilize anymore.
Yeah, which, you know, I mean, as long as I'm never growing or learning as a clinician, you can just stick to these cards for the rest of your life. Unfortunately for you, I'm learning fast, so. In any event, it's a common situation to be like, okay, I would say this, generally speaking, it's life over limb. And put pretty simply, PHTLS literally gives us criteria to say that if you have penetrating injury to the torso or the head or the neck, then we aren't going to backboard, which means we might use a scoop stretch. Now, Mr. Witcher the other day was talking about, he said, hey, how do you guys feel, or how do I feel about them using the scoop stretcher on the patient in the stairwell? And I said, I don't feel terrible, but as long as they know that that person would be criteria for backboard. And he said, no, we'll still fully immobilize them, we'll just use the scoop stretcher. And my response to him was, I don't know that that's real.
I talked to him about that. I told him, he was like, no, you can full immobilize on that. I'm like,
Yeah, I don't know that.
we were not supposed to full immobilize on that thing.
Sure, yeah. That's a separate topic though, because he's saying full immobilization on a scoop stretcher. And I'm like, look, Mr. Witcher is, if not the best medic I've ever known, he is very close. He is a staggering human. I am, however, pretty sure that you can't fully immobilize somebody on a device that is made of two separate interlocking pieces. So to answer the question about the stairwell, I'd say that patient, there's an indication there for a backboard. And if that appears on a test question, backboard would be the right answer. The only thing that would supersede that is a life over limb decision. Like if you said, I was sure they were going to die while I was doing the long, arduous, not proven effective and helpful thing of backboard. I'm like, great, I love that. Let's get out of here. So penetrating injuries is one of the main reasons where we won't necessarily need to do full spinal immobilization. We can use a screw stretcher. But again, this comes back to the same reason why I was saying, look, there are instances where it's like you need to get off scene and go to a trauma surgeon. So it's the same thing here. Internal hemorrhaging. Penetrating injuries have a strong likelihood to cause internal hemorrhaging. In many cases, we will want a person with penetrating injuries to be in semi-Fowlers. Don't be misled by the slide. I'm not saying all of them. I'm just saying often. You get a poked hole in your lung, you're not going to be laying flat on your back. Cervical collar is okay and pretty easy to put on. Scoop stretcher is in theory easy as well. And just consider that trauma centers are going to be very, very common for chest injuries. There's a lot of important stuff in there. We've talked in the past essentially about doing an appropriate neck assessment, including midline trachea, the presence of JVD. Let me ask this. Is jugular vein distension always pathological? Is jugular vein distension always disease process, bad? You're like, I want to say yes, but he's phrasing it like I should say no.
Absolutely.
Yeah. Well, the answer is no. There's a reason why when we technically measure JVD, we have to put them at a 45-degree angle. Because if you sit somebody all the way up, we should experience flattened neck veins. We are increasing the pressure. It becomes less obvious. If I lay you flat on your back, most of your life, I suppose depending on your career, isn't spent laying flat on your back. And so therefore, we would see JVD on most humans when they lay flat on their backs. Is that only Destiny? Let's go. So, JVD can be normal. We are never referring to it in a physiological sense. But if you're like, it happened time and time again, I'd see somebody flat on the stretcher and they're like, whoa, JVD, this is cardiac tamponade or whatever. I'm like, oh, that's awesome that you know that. Let's sit them up though, because your neck veins will be distended too if you lay flat on your back, right? So by definition, that's essentially how it's measured. We're also, of course, searching for cervical step-off. Again, when you're doing your practicals here, kids, make sure that you are doing these things, not just saying these things. Now, jugular vein distension is measured at 48, and despite what many of the clinicians that you do clinicals with, that is in your scope to do. It's occurring to me as I'm speaking. We didn't practice that at all, but I don't really know how to practice that. So Mr. Harris was going to let Rose do one.
Oh, yeah.
I was like, that's a no? That is a no.
Oh, I know.
I'm so proud of him. Absolutely not. Jugular vein distension, what I need you to think is that pathological JVD is evidence that blood is not completely returning to the heart, right? It's backing up outside of the door. Something is not allowing blood to return to your heart, which is essentially only a couple of problems. Now, be careful with this language. It is often the first visible sign. I'm not saying that it's necessarily early. I'm not saying that it's necessarily the earliest. It's just, if you see JVD, you know, your person's at a 45-degree angle, they've got chest pain and JVD, that should make you think immediately, wait a second, I don't think blood is getting back to your heart like it should. Okay? Now, this is traditionally just one of two things. It is either because you are experiencing cardiogenic shock or right-sided heart failure, or because of obstructive shock. So to zoom out and kind of make this, I think, easier to retain, JVD means something's squeezing your heart, or in some way your heart is failing. Now, admittedly, most of my career, I wasn't like well-versed in JVD, so I didn't spend a ton of time looking for it, but it's not always as pronounced as these pictures make it seem. Does anybody know why I'm highlighting a tension pneumothorax leads to JVD here.
The hemothorax wouldn't.
Why would a hemothorax not have JVD?
Because it's back into
Because
this
let's
one,
go with
not
something
this
else.
one.
Yes, say it again?
The blood is just draining into the lungs instead of stopping at the.
Right, because with low volume, I'm not getting a lot of backed up before the heart, right? Why would a pulmonary embolism cause JVD? It has nothing to do with the heart. That's right, right? Because if blood flow isn't able to go through, then it might back up. Which means that if your patient or a test question says they have JVD, which implies that it's pathological, that should put you immediately in the wheelhouse of one of these things. Now, the absence of JVD doesn't mean they don't have these things. It just means that we're not far enough along in the pathology. But if you see JVD, you're like, oh, okay, that's 4 things. And if it's not right-sided heart failure, then it's obstructive shock in some way. What's one of the easiest ways? If I saw JVD and I was on the fence between thinking, is this pneumo or is this tamponade, what would help me distinguish them? Heart sounds, lung sounds.
Chest rise.
Yep, chest rise and fall, yep.
Would it be like the tracheal deviation?
Tracheal deviation is a dead ringer. Nothing causes that except for that, but it's also like the last thing we see until they die. Tracheal deviation is saying that tension pneumothorax and tracheal deviation are essentially associated is the equivalent of saying, I'm not going to give fluids until I see hypotension.
So what instance did you see DVT?
That's in your legs, and often for prolonged sedentary periods or surgeries. Now, jugular vein distension, pathological, is one thing. Jugular vein flattening means not instead of fluid can't get through the pump, essentially we're having poor venous return, which is almost always hypovolemia. Now, since in a natural state I don't see any of your jugular veins, using flattened veins as a criteria is, what do I want to say, precipitous at best. Like, it's something that you will probably only know in testing world. Like, if you see the phrase flattened neck veins, that has to be the most intentional key in a question ever, right? Because again, if you look in a mirror or look around, not a lot of us have obvious jugular veins. It would be inclined to say they're all flattened. And it almost exclusively is implying hemothorax. But now, when we're doing these chest assessments, we need to expose, inspect, and palpate them. We gotta look and we gotta touch, right? We're looking for life threats because if we find them, we have to immediately involve care, right? Remember, our life threats kind of move in 3 major groupings. Do I see any across the room? Do I see any now that I'm looking at your ABCs? And did I find any that were hidden now that I'm doing a physical evaluation, right? That is your game. Your entire job as clinicians is life threats and shock. That is your entire job, even as medics, almost exclusively, right? In many ways. So the big first game is, well, I just need to keep digging until I find a life threat. And then if I don't, then I just got to keep singing until we get to the hospital. Again, we're looking for DCAT BTLS. We're looking for both adequate chest rise and fall as well. What would it imply if my guy's chest was rising fine but had some issues with chest fall? Auto PEEP. Whew. Whew. He was essentially retaining gas. He was having issues of the gas escaping. And we're looking for symmetry, and we got to nail this home a little bit too. Rose?
I just have like a kind of a random question.
Yeah.
Is that just like pretty much pretty easy to get? Like as in
What's that?
shock, like when you're a kid and you're sleeping and your parent comes into your room like wake up and starts banging on things, and
you're like,
yeah,
Mhm.
is that would that be
It kind of, like, kids turn pallorous and cyanotic really easily. Like, if you got a baby and he just gets so excited, like, he will literally blanch his own, just get paled out and stuff because of what's, I think, largely happening there is vagal stimulation, Your sudden reaction essentially is causing a shunting issue. So it's not shock in the sense that, like, it's like saying, is VQ ventilation perfusion mismatch a problem? I'm like, well, we always have a certain ratio of ventilation perfusion, but when we say VQ mismatch, we're talking about the pathology. It's like when I say JVD and you're like, well, there's always a certain level of distension, otherwise they'd be flat, right? Like, right, but when we say it, we mean, so even if by definition we said, well, that's momentary and not, what do I say? Not sedentary, tertiary. I just said momentary hypoperfusion, right? But it's not what we mean when you say shock, because he just instantly returns to baseline. But yeah, that's essentially what's occurring. That's why their skins will change color. All of them, all their skins, yeah.
You know, when, okay, babies, sometimes they stop breathing without reason, and they just like watching like this. Have you seen that?
Did you say when babies stop breathing?
Yeah, they stop breathing. You can look at them and they're just like this, but they don't have like something.
Yeah,
like
nothing's wrong.
Yeah.
Yeah, I mean, I have seen, there's certain things that basically their body doesn't adjust super well to those sudden changes because they have zero reservoir. They have no like storage of that stuff. So if you bear down quickly or get so excited, will just cause immediate shifts essentially to their perfusion.
What we do for that?
Nothing.
Watch.
Yeah, absolutely. Yeah, because they just self-correct. You know, they relax, their body returns to normal. Unless you're talking about, there are some things that can look like that called TET spells, which is a very different thing and involves holes in the heart. But
No, they don't.
yeah, but it can be normal. Like my boys would get excited, they would look like death. I'm like, oh, I've intubated people that look like you right now. Chill. Like. With impaled objects, make sure that you know that impaled objects and open pneumos are both life threats. If this guy had a knife sticking out of his chest, even if he wasn't bleeding to death, and you said, do I see any obvious life threats? And the adjunct said no, they would be wrong. Which means essentially, you know, if I walk up, well, I guess I should be a little vague. I mean in the chest. If a guy's got a knife here in his arm, I don't know that I would call that necessarily a life threat, but I probably would address it in the life threats because I don't want it to get worse, right? So if Landon, you know, he's got a steak knife sticking out of his arm or God forbid his chest, I would say, okay, what's my general impression? Oh, you see a handsome young man, looks like he's a gardener perhaps, and he's got a knife sticking out of his chest. I'd be like, cool, any life threats? They'd say, well, you've got a knife sticking out of the chest. And I'd say, hey buddy, I'm gonna put my hand on this because I don't want it to move at all. And now I'm basically locked here like it's manual stabilization of the spine, right? It's just like if I saw a fractured arm, I would want somebody dedicated to making sure that didn't become a life threat, even if it wasn't one now. If I put a knife in your scenario or in your practical, I will expect you to immediately stabilize it, even if you don't immediately secure it. You see what I'm saying? It doesn't necessarily mean you throw up a bunch of rolls of gauze and you do all this stuff and you're like, okay, does he have a pulse? And I'm like, no, but that looks beautiful, right? So make sure you're aware of that. Also make sure that open pneumothoraxes are life threats and can be immediately, not corrected, but addressed by a gloved hand, which is an occlusive, not dressing or bandage, but an occlusive thing, right? Which means if you're like, dang, a hole in his chest, whew, not good. Well, my name is Steven, sir, what's your name? I'm like, what? Put your hand on that while you talk to him. Put your finger in it for all I care, but it needs to be plugged up. This is so cool. This is one of my favorite parts of the entire book. The Deadly Dozen. Wow, 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 wow. So catchy. Now, admittedly, I don't think all 12 of these are worth a discussion necessarily. Maybe they just needed 12 because like Deadly 11 was lame. I don't really know. And I group a few of them. And in fact, you'll even watch as I built these slides at like 2 in the morning that I start numbering them and then I just stop. So don't worry too much about that one. But it's funny because I look at this and I think, God, that is what the AEMT class should be. We're talking about the chest, list all the things in the chest, know what they are, know what separates them. That's what it should be. That over and over and over. Oh, let's talk about the brain. Deadly dozen for the brain. What's the similarities? What's the difference? Deadly dozen for the abdomen. I'm just gonna deadly dozen the whole thing. I think it's great. Does anybody see anything strange about this? Please say yes, please say yes, please say yes, please say yes.
Well, I mean,
Ooh, wow, it's like you're connected by mycelium, your whole... What's weird about this? Yeah. Did I teach you anything different?
No, you.
No, I definitely didn't teach that because they just changed that like 4 days ago.
No, you tell us for babies.
For babies? Yeah, literally all ACLS and BLS instructors, of which I am, essentially, you had to update to the 2025 curriculum for the AHA. We have added back blows to adult choking.
No, you lie.
You are watching EMS evolve in real time. Wow, wow, wow.
Why not the Heimlich anymore?
I think that the Heimlich has changed because of back blows. They stopped calling it Heimlich because in England, they do back blows so far as I know. But there was like a disagreement about what happened. So, okay, so get ready to relearn just a small portion here. You know how when you've got a baby that obviously they can't talk, so we largely skip that part. And the first thing you do is back blows, okay? Also do that with adults now. We just can't put them over their arms. So I say, hey, cough, and he can cough. I'm like, great, keep coughing. If he stops talking, then I grab him essentially, I pull him forward, 1, 2, 3, 4, 5, and then I go to abdominal thrusts. Get it in your minds, little robots.
I'm scared if someone came up to me and started beating me.
I can assure you, while you are suffocating, you can think of nothing else.
Oh, you haven't seen babies. It's like really heated.
Dude, I can't remember if it was Atticus or Henry, but one of the two of them came up to me, blue as the day is long. And I was like, what are you doing, dude? Chill, take a breath. And he was like, I was like, holy crap. And I was like, buddy. And he just started to fall, and I just grabbed him by the neck, and I was like, wham, bam, bam. Chunk of something flew out of him. Crazy.
You want to like lean them forward or something?
I did.
Okay, yeah.
But mostly, not really. You just got to hit him in the back, and I'm not very tall. Anyway, we've added back blows to even adult. So there you go. You're welcome, and I'm sorry. In any event, another thing we're going to talk about here is airway disruptions. Now, disruptions are not deviations. A deviation is a shift of your trachea, but a trachea disruption means that it has severely broken. So a tracheal disruption is like me reaching over there and just tearing your trachea in half. Okay? Disruptions are a very different experience than deviations. Deviation implies what condition? Tension pneumo in the very late stage, right? But a tracheal disruption denotes a profound trauma has occurred. Now, even if the exterior of your skin doesn't get broken, you still get air escaping into your thoracic cavity and neck, causing subcutaneous emphysema, right? Like crackling under the skin. So if you feel subcutaneous emphysema, what might you suspect? Tracheal disruption. Now, if you had it happen in your bronchi, we'd call it bronchial disruption, right? Essentially, that term is largely meaning these things are getting severely torn. There's a rupture in between here. It didn't start with a D, and I didn't like it on the slide, so I didn't include it. But essentially, it's just the middle ground there. A rupture would be a tear, whereas the disruption is like more than that.
And would the rupture cause sub-Q?
Yep.
How does
Vitamin G, all the way to the hospital. Put a guy on a non-rebreather, call a paramedic so that they can decompress if they need to, and otherwise get to the hospital. If your guy tore a trachea, he is on a very short timeline.
The non-rebreather not like be hurting him?
It's not pressure,
That's true.
How does it?
but guess why you don't put a CPAP on them? Because it will cause a pneumo.
Can you see it? Like because we.
If it's open, well, I don't know. I Googled a bunch of pictures of it, and I didn't include them because it gave the appearance that it was not visible, but I want you to think severe, so I didn't include the pictures. So airway disruption means that a major trauma has occurred. We get severe respiratory distress, subcutaneous emphysema, and hemoptysis, major issues, right? Asymmetrical chest because we're developing a pneumo and potentially a tension pneumo, right?
Is suction and airway still treatment if it's bad enough? Like
What's the indication for suction?
the fluid in the airway?
Yeah, so if he's got that, do that. Now, chances are you're going to be chasing a horse that never stops, but dude, that's wild. Trying to intubate people that are just geysers, you're just like, will you just go into cardiac arrest already so I can intubate you? Like, I'm just suctioning and suctioning and suctioning and suctioning. I can't see it. If I just reach in there and stop his heart for like a hot second, get all that fluid out of the way. I thought about in the past of like giving like adenosine to give like a transient asystole experience just so I could get the suction right or whatever. I'm like, definitely don't want to try to defend that one in the Supreme Court. I'm like, oh, I tripped, started an IV and ran a denizen, and then anyway. You can use a salad method, that's different, but. Traumatic asphyxia, what this isn't is, I think we kind of think that like, oh, if if the ball gag goes down 2 notches and now I can't breathe at all, that's essentially traumatic asphyxia. But what traumatic asphyxia is specifically compression injury. So essentially, if I'm pinned between a car and a wall, and that is not allowing my chest to expand, we would call that traumatic asphyxia. But so too is the sudden blast of it. Like if I get hit by a beam and it causes a instant widespread compression injury, it doesn't have to be persistent, I guess is the point. And that can cause all kinds of ruptures and issues. What is exophthalmos? Huh? Some Greek guy? Yeah, that does sound Greek. It's bulging eyes. We only barely referenced it when we talked about hyperthyroidism. Graves' disease stuff.
Is it
Bulging eyes. What's the difference between subconjunctival hemorrhage and conjunctivitis?
Blood in the eyes.
Blood in the eyes as opposed to
Inflammation.
inflammation. Very good. Let's talk pneumos and hemos. Now, admittedly, I'm going to include pneumos and hemos as almost, I don't want to say synonymous, but I'm going to paint the picture here like a hemo and a pneumothorax can be all of these things, and they can. But you'll go in your entire career and never be obviously hemothorax. Like it's far rarer that tension hemothorax develops. It's possible, but it's far rarer. Now, spontaneous essentially is the one that is occurring with like daily living, right? I had a cough, and then my lung collapsed. Okay, that's not supposed to happen. There I was doing some menial normal activity and my lung collapsed. That's spontaneous, right? And it's usually the result of a bleb or some type of diseased tissue that has now caused a collapse. Simple comes with a more obvious story. There I was falling in love and she shot me, right? Got it, right? No bleb, no mystery, hole in the chest, right? What it really means to have a simple pneumo is that you're getting air in the pleural space, or blood, if it were a hemothorax. It's not tension until it starts to become obstructive shock, which I don't mean to mislead you. I don't mean to say that unless you have low blood pressure, it can't be a tension pneumo. Incidentally, low blood pressure is one of your strongest indicators for tension pneumo because as pressure develops on the mediastinum, your heart can't break it up. Now, I already said all that. Moving on. Now, this is my little mind map, essentially, because we got a bunch of different terms. And this is, I wrote this and I was like, I don't know if that's helpful. But what you're thinking about, tension pneumothorax, is your big thought process. Is this tension pneumothorax? And you suspect that based on the presence of JVD, hypotension, or at the very last moment, tension pneumo. Which I don't mean to say if you see tracheal deviation, they're instantly dead. But they're not far, maybe 2 instants, right? I've only seen 2 times in my career where somebody had a obvious tracheal deviation from tension pneumo and they lasted the entire trip to the hospital. So, in any event, tension pneumo is the end of these issues. Simple is far more likely to cause a tension pneumo than a spontaneous, but it's possible that both do. It's also possible that a hemothorax can result from spontaneous or can cause spontaneous or simple, but it's usually pneumo. The other terminology there is open. And so your real learning points and thought processes are, okay, I have to monitor this guy to make sure that his spontaneous and or simple does not become a tension pneumo, or if it does, I see it happening. The other one is how if your simple pneumothorax is an open one, because that requires intervention from you in the sense of an occlusive dressing. Now, naturally, our treatment for these things is high flow oxygen, but the only fix for that really is surgery to correct why ever his lung has collapsed in the first place. Now, we have to call paramedics, and if I run the practical, you know how usually you're like, I'm going to consider paramedics, and then maybe you forget or whatever. If your person has a pneumothorax, calling paramedics will be worth an enormous portion of the grade, probably 5% for just remembering to call paramedics, because they can fix it in the field, And so we need to get a hold of them quickly to see if it's possible. Now, it doesn't last long, so it's not a permanent fix, but it can definitely save their lives. We also may need to do ventilatory assistance with a pneumothorax. Why am I saying cautiously? If a guy needs a BVM, shouldn't I just get after it? Sebastian? Because of the pressure, what might happen? If my guy's lung collapsed because he's got a hole in it and I force more air into the pleural space, I'm going to cause it to collapse and shift the mediastinum. That's right. Which is why we definitely don't apply a CPAP, right? Now,
How you BBM?
how do I BVM?
No, how you do it
With 1 foot up.
with precautions? Like, if you have tension pneumothorax and you have to BBM, what's
I'm-
the difference between
Fair enough. You know how oftentimes I'm like, hey,
chest?
when you BVM, I want princess breath, monitor end tidal and stuff like that. If you suspect your guy has a pneumo, I'm serious about that stuff because you're going to make it worse for every breath that you don't administer perfectly to reach the appropriate amount of chest rise and fall. As you look over, you let a few heavy ones go and more air escapes. So you need to be very conscientious of your bag. So I wouldn't say that anything necessarily changes so long as you are always perfectly bagging in the first place. But it's all the more so we are in danger of causing a problem with that. Your big hook is, okay, so I think this might be a pneumo. Is it a tension or not? Because the tension is definitely going to kill him. So we might see signs of lung collapse as compensatory mechanisms increase. Higher heart rate, higher respiratory rate, altered mental status, confusion, these kind of things. Nobody is surprised to hear chest pain or dyspnea. Nobody is hopefully surprised to hear diminished unilateral lung sounds, right? As a lung collapses, it makes less sound, and therefore associating hypoxia. Would it also, yeah, absolutely. How would it affect end tidal? Yeah, it sure does. It sure does. It depends where you're marking it on the timeline. Consider essentially that a pneumo means that now we're getting half the amount of respiration that we want. What is happening here? What you doing? What? I could barely hear myself talk.
Sorry.
Okay. Hi.
Sorry.
Okay, so with the signs of the pneumo unilateral lung sounds issue, if I'm getting 50% of the gas exchange, I'm now getting 50% of the oxygen in I need, I'm getting 50% of the CO2 out that I need, which means initially we'll see CO2 and end tidal rise because we're not getting it out as much as we need to. But as we start to hypoperfuse, we will then see it drop on a long enough timeline.
Is there a target range then that you're in?
35 to 45.
So it's still the same.
But again, we're being cautious because if I'm like, oh no, it's starting to build up, I need to work against that. And I'm like, okay, now you're creating a tension pneumo because you're overdoing it over there. So we're just trying to be easy there. Now, this is why I thought that obstructive answer was somewhat misleading on the test question. This is directly from the book. Both a pneumo and a hemo occur in both a pneumo and a hemo occur in 80% of all penetrating chest trauma. I've seen a bunch of penetrating chest trauma. I have seen a bunch of people die from penetrating chest trauma, and I've seen a few that I was sure was a pneumo, but I have never in my career been like, wow, clearly this is a pneumo and a hemo. But I think the book is probably correct to say that that means all the times that I saw it, it was not obvious to me, in part because they were probably dead, and those signs are difficult to determine. You just see a dead person. But the point is this, is that if you get a penetrating chest trauma, you go in saying, I'm just going to go in thinking this is a pneumo or a hemo, and then be delighted when it isn't. Okay? Now, an open pneumo, you'll hear this sometimes referred to as a sucking chest wound. Truth be told, I've seen a billionty of those and never seen a sucking chest wound. Yeah, dude. They have to be like the size of a $50 before they start genuinely pulling in air, which is why I don't super mind that I find occlusive dressings completely absurd and a waste of time. Wait, maybe I shouldn't say that, and certainly on a recorded situation. Like, that's the right answer. If they got a hole in their chest, especially if it's a sucking chest wound, you want an occlusive dressing. Not only are they like not super effective, but usually they're not even allowing air to transfer very well unless they're giant. let's pretend I didn't say all that stuff. If you see a hole in the chest or in the neck or in the abdomen, it gets an occlusive dressing, so air doesn't go back and forth. Okay.
You can. So if you have something chest wound, you will hear something or see this.
You could hear sounds, air escaping, see bubbles. Subcutaneous emphysema is a dead giveaway for it because essentially it's escaping into the lining and the walls. Now, I don't care really about 3-side and 4-side, but I'm basically the only one. If I have a practical where there's an occlusive dressing and Landon does a 4-sided and he does a 3-sided because he knows that that's the thoracic cavity and it's going to self-burp and stuff, I'm like, cool, full points, whatever. Neither of them are working very well, and I don't care. But by definition, the point of a 3-sided occlusive dressing is so that it will vent itself. And on the chest, that makes more sense because we have the gas exchange, which means the only time a 3-sided is, I guess, wrong is if it's somewhere where there isn't air moving, like perhaps on the neck or perhaps on the stomach. Now, I don't know what the registry is going to say, and I don't care enough to go in depth on it or write test questions about getting you to differentiate between 3 and 4, but that's what the answers would be if they cared. Paper bag. Why does paper bag syndrome occur? Guy slams up against his steering wheel.
Closed glottis, inflated lungs.
Ooh, we all know about this. Say it again, Destiny.
Deep breath before impact.
Yep, deep breath before impact is half of it. Why is it causing a popped lung?
Increased pressure.
Pam?
Well, they only pop because they see the impact coming, so then they hold their breath in.
The person holds their breath, which is causing their what?
When you have impact, it makes a smaller space building up pressure. Pressure's got to go somewhere, so it,
You close
You are
the
the only-
glottis.
yeah, it's a closed system.
Basically, you do this. I mean, you can feel it. If you did it right now, let's all do it together. 1, 2, 3. I mean, you can feel your throat closing, right? And so once that's closed and your chest is full of air, pop it like a paper bag. Bow. Later, Otis. So, signs of tension pneumo. One of the earliest visible signs is JVD, right? If I see JVD, I'm like, oh, whoa, this is compression of the heart in some way. Is it tension? Is it tamponade, right? Also be conscientious, essentially looking for BVM resistance. We're starting to get there. I had a few people in my scenario say, how does the bag felt? Which is like Christmas cards to me. I love that. So much you can gain. I watched so many different scenarios or practicals where I'm like, man, if he just was like, how does this feel? And I was like, oh, glad you asked. Way too simple, way too easy. A couple of things about my scenario I was thinking about later in the day. It was like my third, were you the BVM one?
I was like,
She was like, wait, if this, every scenario that went by, the hole in his cheek got bigger and bigger and bigger because I felt like it wasn't becoming obvious enough. What I hadn't considered that trying to bag somebody with an enormous hole in their cheek would render it largely completely ineffective. So consider that. Secondly, one thing that I don't think I highlighted for every group is what would we do if we came in and a kid had shot himself in the face and had signs of profound hypoperfusion and a heart rate less than 60? CPR. Yes, get out of there, but also CPR. So we didn't have any groups doing compressions on that kid, and we should have. His heart rate was less than 60. He had obvious signs of hypoperfusion. Okay. Hyperresonance. Don't try too hard on this. I'm not going to ask a test question where hyper or hyporesonance is the right answer, but it might help you answer the question. I just want to expose you to it in case. I think it's the most ludicrous thing in the world. How you do it largely is you put this. I'll do it on his chest essentially, is you would put 2 fingers on his chest and then 2 fingers and tap that while essentially listening for the tonality of it. It is very difficult to do on the side of the road and even harder to do bouncing down the road in an ambulance. We're looking for pitch changes. I'm not teaching you that, and I don't care about it. But here's the association that if you get asked the question, you will know how to answer it. Hyper air. Hyper air. Hypo blood. See the O's? See the air? Yeah.
I took a practice quiz for the AET.
Mm-hmm.
Pretty sure that there was a question about tension room, and it was like hypo.
Boom.
What would you expect to hear?
Knock it out. Okay, close your eyes. Hyporesonance is associated with what? Liquid or a gas?
Liquid.
There we are. We're fine. It's a dull sound. High pitched through the air. Instead of, it's. Okay. Flail chest. Our definition of flail chest is 2 adjacent ribs in 2 places fractured. Right? Doesn't mean if there's one on the left and one on the right and that's now 2 ribs. No, we're talking about a structural component of the chest is disintegrating. And so now we have paradoxical movement. What does that mean? Opposite, right? So let's all do our little plane thing. All arms go out, right? Okay. With your right hand, show me what an example. Like, we're all squirrels. Okay. Show me what it would look like if I had asymmetry on the right side. Right? Asymmetry is essentially implying either this up or down, right? Now show me what maybe paradoxical would be. Opposite, right? Very good. We got a couple little planes, a couple of little pretty fairies. We got all kinds of different little representations in here. Lovely. Now, paradoxical implies flail chest. I don't know anything that causes it that it isn't that. How do I treat it? Well, it's mostly what I said on the board here. Internal splinting is done with a BVM. By assisting them with their ventilations, I'm making sure that their lung stays inflated, because once I've got structural integrity falling to pieces, we might have a lung collapse. So hopefully nobody is surprised to hear that what often follows a flail chest is a pneumothorax, right? We don't do external splinting, and you might see this on a registry because they definitely taught me to do external splinting. We used to put sandbags on people's chests. It's not crazy. What do you give me that look for? Because it, what's up?
Would this be a case where you would want to throw a peep valve on the BVM?
So that, well, and that's probably a better answer to Alanis's question. How do I be cautious with a BVM? Well, if you put a PEEP valve on there, you can be sure of the pressure in a certain sense. So yeah, that's probably a better answer to her question. Yes, but truthfully, I want to say, God, one of these years, I'm going to graduate a class where every time we BVM, they're like, hey, numbskull, where's my PEEP valve? We are not there yet, but we should be. And that's all of your faults, definitely not mine. No, I don't think many of my adjuncts super care about it, and I forget to enforce it. But what was I saying about that? Oh, they would teach me to have a sandbag, because the concern is that yes, lung collapse is bad, but a broken rib that stabs it is worse. And so if I put a sandbag there, it keeps it moving as one unit instead of this kind of opposite shift or whatnot. Well, I'm glad you're all much smarter than us at the time, but we didn't know, and that's the plan. So don't do that now. However, you can they'll find relief if you give them like a pillow to sit there. It'll still allow the movement, but it kind of makes it so it's not shifting. But that's not considered splinting. So we don't externally splint. We definitely call for paramedics. Why am I calling for paramedics, and why would it be worth so many points?
It could develop a pneumonia.
Yeah, because if it becomes a pneumo, they can decompress. They can't fix the flail chest, but they can fix what follows it, perhaps, or at least temporarily, right? Now, flail chest, we need to pay attention to the rise and fall, essentially. If I've got massive trauma and crepitus of the chest, I'm expecting a flail chest, especially with that paradoxical movement. We might note whether or not, what would it mean if I've got a guy with a flail chest, but his lungs are fine, what would I consider if his heart rate starts going up?
Well, heart rate go up as compensation, so he might be bleeding internally.
He might be bleeding, and if he's not compensating because of blood loss, then he's compensating because of, yeah. If I see a guy with a flail chest, he could be completely fine. A lot of pain, but completely fine. A little tachycardic because he's in pain and things suck. I go ahead and give him fentanyl, ketamine, Toradol, whatever. It calms him down. And then I start to notice that over the whole transport, I keep watching that heart rate, 110, 111, 115, 117. I am starting to suspect that he's either bleeding internally or developing a pneumo. And in fact, it's not shortly after that tachycardia that I start to notice JVD. Now I'm sure of it. Right? Now I'm sure of it, because not many things cause JVD that isn't just a complete obstruction of the backflow. Make sure that you're aware of occlusive dressing. Something hit him in the chest hard enough to break his bones. If it poked a hole in it, put an occlusive dressing on it. Pulmonary contusion. I punch you in the arm, it sucks. It sucks for a couple of days, and it's not that big of a deal because you got another arm and you can work around it. But you get punched in the lung to the point that it causes bruising and alveolar collapse or alveolar capillary destruction. That can be a major problem. Pulmonary contusions are a big deal. If you put a pulse ox on a person who got hit in the chest and he's at 86%, more often than not, the cause of that low pulse ox is because his lung tissue is bruised and not working right. Now, we still give oxygen for that, but it may not be the solution. Here's a bunch of pretty pictures. So be careful. All paradoxical chest movement is unequal. Not all unequal chest movement is paradoxical. Because of the negative pressure space, my thoracic cavity needs to resist the vacuum. If it's broken, it won't. So part of it will sink in. Okay? Okay, pumpkin? I don't remember what I want to say there. Oh, green stick stuff. Look, if you've got a kid with a fractured rib, something hit them hard, right? We should suspect internal injuries and the possibility of abuse. That is all. Here's a sneaky way of me making sure we know what ARDS is. ARDS, right? It's a pirate's lung condition. No? Oh, I know you got it. that wasn't the issue. There it is. Oh, thank God. Okay. What happens here in a pulmonary contusion is that you have lung damage, and so your body wants to fix it. How does it do that? If you cut your finger, how does your body want to fix that? Yeah. It's going to send blood flow there for clotting factors, but also for anti-outside world stuff. It wants to nuke it and kill it and flood it, right? Okay. What we're talking about here is not just the clotting process, but primarily for this discussion is the inflammatory process. If you have a bruised lung, your body is going to send a bunch of inflammatory prostaglandin stuff there to cause fluid to rush to it. Because of that inflammation, you're going to get fluid around and then in your lungs. ARDS, do you remember the definition of ARDS? I thought of you when I wrote this because you read it off the board. That's what it's called, but I said, what's non-cardiogenic? I was like, whoa! Oh. Yeah, I was like, whoa, that was cool. Yeah, non-cardiogenic pulmonary edema, that's ARDS. If you said, that's all I know about ARDS, I'd say, okay, then add one more thing to it. ARDS is non-cardiogenic pulmonary edema because of, starts with an I. Inflammation. Very good. That's what ARDS is. Because of that, the rupture causes the inflammation, causes pulmonary edema, causes a mass shift in our ventilation and perfusion, right?
Why is it not VP mismatch?
I look it up every year. I forget every year. Well, I think that's like the common misconception. I got into a just shy of heated debate with one of the medic students this year, but I think it's French for something. I think that the argument is often made, oh, it's Latin, that's why we say Q 5 hours or something, or whatever, and I'm like, no, that's why it can't mean that, but in any event, it's perfusion. Now, costochondritis, this is often the wrong answer on test questions I have seen. It's the inflammation of your intercostal muscles, right? It's benign inflammation. Look, if you get the flu and your chest hurts afterwards, if it's not the literal infection that's hurting, it's the fact that you've been coughing for 6 days straight. It's causing costochondritis, inflammation of the intercostals. The reason why they like to include this a lot is because people will call for chest pain, turns out they got a fever, and it's not ACS, it's just type of infection. And so you'll need to be able to differentiate between the two, saying, oh, this is a lung issue with musculoskeletal involvement of the chest wall, not a heart attack. Now, be careful in testing world, right? There are some questions that end with the phrase, what should you suspect? And I always want you to suspect what? The best or the worst? I always want you to suspect the worst, right? But if I say, which of the following is the most likely, or some other phrasing, what I'm trying to say is based on the wording and the evidence here, Which of these should you make? Like, if I write a question that says, your patient has chest pain, what should you suspect? Heart attack or unstable angina, what do I want you to say? Heart attack, because what you should suspect is always the most catastrophic. But if I say, your patient is experiencing chest pain with a history of atherosclerosis, the paramedic says that the 12 lead shows no ST elevation, which of the following should you most likely suspect? Now I'm trying to say, okay, based on the fact that there's no ST elevation, I actually am thinking unstable angina. I'm not thinking catastrophic anymore because I gave you a list of, I'm trying to get you to differentiate the symptomology. Cardiac tamponade, essentially, right? Give me just, your left hand will give like a heart, right? We'll take our right hand, this is our pericardium. Right? And as our heart beats, essentially, it beats inside of that pericardial sac. In that pericardial sac is about 50 milliliters of fluid to keep it lubricated and keep it safe. Pericardial tamponade or cardiac tamponade, all real synonymous. You can sometimes get over a liter and a half of fluid in there, just compressing the heart, not allowing it to do. What's one of the dead giveaways, signs of cardiac tamponade? JVD, muffled heart will do, right? Not a whole lot will muffle a heart. It's not a pile of fluid or you being too far away, right? JVD, because the blood can't get back to the heart. And if it's not a tamponade and you say JVD, what do you suspect it might be? Say it again. Yes. I'm glad you remembered that, but it's probably going to be a pneumo. But yeah, right-sided could work for sure. That's just, I would probably say that. I'd be okay if my entire class graduated not realizing it was associated with right-sided heart failure, but that is true and that's super cool. But it's probably, if you see JVD, it's going to be pneumo or tamponade. Now, what is Beck's triad? I can never remember how to say it. Triad? Triad? Muffled heart tones. What is it?
Low blood pressure.
Low blood pressure, I'll take that.
JVD.
And JVD, right? Or narrowing. Make sure that you know Beck's triad. Make sure that you don't confuse it with Cushing's triad. Now, we're not in neuro, but if I write a question on the final, it's definitely going to be, this guy's got a tamponade, what do you think it is? And he's going to have high blood pressure, slow heart rate, and stuff like that, and you'll have to know, oh wait, it's not Cushing's, it's Beck's. How I remember that? Beck's involves your body, Cushing's involves your cranium, right? I wish it was Hex triad. That would be much more convenient. Take a quick break and then we'll just blast through, like 2-minute break here. And then we'll hit the highlights. I have them, I just haven't pushed it to update. I can do that while we're chilling. Yeah. Now, much like we were talking about pulmonary contusion, bruising of the lung tissue, myocardial contusion, also a major issue. Because if you have bruising of the cardiac tissue, then you're going to get reduced cardiac output, which is going to trend towards all kinds of stuff like ischemia and dysrhythmias. So myocardial contusion is a big deal. Commodia cordis, what up?
So for like I guess not cardiac contusion, but myocardial contusion, would that also have like excess fluids because it's sending fluids to repair the immune response?
Sure, yep.
So would that could that turn into like a cardiac tamponade?
I don't think so. No, because it'll be intravascular, I think, and I don't think it's going to cause some kind of pericardial infusion. So I don't think so. Now, commodia cordis. You remember me talking about essentially, somebody summarize for me, give me a hand here, what the purpose of, you already doing it? I mean, you probably can, honestly, but what is the purpose of the sodium-potassium pump?
To provide energy, swap, cause electrical charge, depolarize or repolarize depolarize the muscles, causing contraction?
Yeah, it's not depolarizing necessarily or technically repolarizing, but it's setting us back to a point where we can depolarize and repolarize. It's resetting the cell, right? Where that's happening in your heart is around this area, right? It's what they call the refractory period. You don't want electrical discharge as your heart is resetting, because if it happens, it can put you into VFib. Now, in theory, if you were to have physical stimulation of the chest, or specifically the heart, in that moment, it could generate electricity and put you into VFib. And where you will almost exclusively see this reference in testing world is, there a guy was playing sports ball, he got hit in the chest, he had seizure-like activity, you check for a pulse and he's dead. Turns out when your heart fibrillates, so does your body, right? It can look like a seizure. It's one of the greatest mistakes in my career. Yeah.
How much energy is usually required to generate an electrical impulse?
I mean, there's a reason why punches aren't always doing it, and it's always referenced in sports ball.
Okay.
Lacrosse, baseball, those are the big ones.
Okay.
Myocardial rupture, a little different there. That one absolutely can lead to cardiac tamponade as it fills that up. Make sure that you can differentiate aneurysms from dissection. The aneurysm is the ballooning, right? The dilation. We get that from high blood pressure all the time. Aneurysm's the balloon, that's the one that'll come with the pulsatile mass. Dissection is a tear in the lining. One of the major differences here that we'll see is essentially the difference of BP in the arms as it balloons and tears and causes an issue. This image is trying to get you to think about, like, look, aneurysm is not good, that's for sure. If it ruptures, that's a problem. But it's not doing anything for our interior diameter, not really. But a dissection can, because if it tears in the lining and that balloon starts filling both ways, then it will diminish things. And so part of the reason why we will see a change in blood pressure, if this is our ascending aorta, this being a descending aortic injury, right? This subclavian artery is going off to your arms. And so if that issue is happening in between or near them, that's why you're getting the different blood pressures in the arms, because essentially you're having an issue before or after one of those arteries gets its pressure, right? Now, charts like this, we're not going to spend, because we don't have the time, a lot of time going over, but this is really how your brain should be working, right? Being able to create a list of this and say, what are the different presentations here? I started to make one, I started to make two that's nowhere near complete, and so I have it hidden. You're welcome to finish it for me. But this is kind of how your brain needs to think. Like, okay, only one of these doesn't have unilateral breath sounds, that's going to point me strongly in this direction. Only one of these has flattened neck veins, that's going to point me in this direction. Your brain just needs to work like a spinning Rolodex, right? What's up?
Hyperresonance with hemothorax?
Whoops.
Very hypo.
Ignore that. Yeah. She made it for me. Yeah. Yeah. Now, she's going to fail a test because she didn't listen to a word I said, but I have the... No.
Would you be willing to write me a letter?
Of recommendation? I never wrote you a letter of recommendation.
Oh, that's right.
Oh, I'm glad you forgot too. Whew.
Oh, I didn't forget. I just thought it was rude to bring up.
No. I mean, maybe it is rude, but it's probably ruder for me to have forgotten it.